Was a young female, 30-year-old, slightly myopic, no past medical history. She had some gestational diabetes, but that had resolved. Recent, fairly acute onset blurring of vision in the left eye. Angiogemas were quiet, the vitreous was quiet, and that is her left colour. It's just quite, it's rather sort of tigroid, pale fundus. And this is the fellow eye, so maybe, probably not much difference between the two eyes. All right, let's move on. Autofluorescence. Anyone? Oh, Mike Michaelides. Yeah, just perfect. Comment on that?
If it appears to be a peripheral ring of increased signal.
Oh, just press the button. Yeah.
There's a peripheral ring of increased signal.
Okay, so she was sent to Mike's clinic, the genetics clinic. And, oh, hang on. We did an OCT. And that shows some edema, okay? Quite diffuse inner layer, cystic. No sub-RPE fluid, which is interesting. And then she has a few cells in the vitreous, quite right. Posterior vitreous. And that is the angiogram, which is quite interesting, isn't it, when you look at the angiogram? What's the first thing that you notice when you look at the OCT and then you look at the angiogram? If you look at the macula on the FFA and the macula on the OCT. So there's a disconnect, isn't it? You'd expect, like most cases, you'd expect to see some leakage there, but you actually don't, which is interesting. The vasculature looks reasonable to me, maybe some mild peripheral attenuation. There is some peripheral RPE kind of hypo change, and there's no macular leakage, so that's interesting. She has got some vitreal cells, and then pretty rapidly she gets right eye involvement. Do you think that's a genetics condition, Mike? Because we sent, well, she came back from the genetics clinic.
Yeah, it looks pretty asymmetrical to be genetic.
It's very asymmetrical.
Yeah.
And if I said the history is over about a month.
Yeah, that's not genetic.
Yeah. So I'm glad you said that, because you said it wasn't genetic.
Thank God for that.
So she comes back to us. We get some... We're trying to work this up. Is it, well, could it be a unilateral retinal dystrophy? Well, it's actually now bilateral and it's too quick, whatever. Is this a case of carcinoma-associated retinopathy? We get some electrodiagnostics. I think this kind of case definitely want to get electrics. So we have some electrodiagnostics. Tony Robson was skulking somewhere in the back, but I'm going to... Oh, there he is, right here. So the PERG was not too bad. The large field was okay, but she's got undetectable flash ERG, and the photopic, which is cone function, is grossly abnormal. So am I concluding that she's good? Well, you tell me.
So from that summary, it looks like there's severe rod and cone photoreceptor dysfunction.
Okay.
And if it's not described in a rod cone or cone rod pattern, it sort of implies that both the rod and the cone photoreceptors are affected roughly equally.
Okay.
So not like RP, for
No.
example.
Okay. So it's leading us again more away from, well, we've concluded it's not hereditary or whatever. Now, I think there is bilateral pathology. Yes, there is. It started unilateral, and within about a month it becomes bilateral. Hang on. It starts unilateral, and then within a month, 6 weeks, she's symptomatic in both eyes, and there's a trace of edema in the fellow eye by about 6 weeks. I don't have the OCT. The fluorescein, as I've shown you, but this would be a very rapid hereditary condition in my book. But
clarification, was it electronegative at the initial and then rod cone involvement later? What was the...
I don't think it was electronegative. Did it say it? Oh, okay. Fine. Fine. Well, then, there we go. That's electrics for you, isn't it? Am I right?
Your dismissed your eminent colleague.
Anyway.
I think it's a shame that you're not showing the traces.
No, you're quite right.
You would say
For
that,
sure.
Tony.
Time is pressing. Anyway, we conclude it's a rapid process here. I think we've got to start thinking about some of the autoimmune retinopathies or carcinoma-associated. Yeah, exactly. So, well, MAR or CAR, Adnan, what is your feeling? MAR, you usually see other features with MAR.
So you've got the two forms of melanoma-associated problems. You get the classic MAR and then the vitelliform light changes. So they don't have the vitelliform light changes, hence the questions about the electronegativity. Yeah. And so it's pretty non-specifically blitz the retina, so all of the possibilities exist.
Fine. Okay.
Yeah.
So we sent her off to the oncology clinic. They did a...
Can I just add, there's two things.
For sure.
Firstly, if it's MAR, the ERGs show changes consistent with selective on bipolar dysfunction.
Fine, okay, which we don't see here. Fine. Okay.
But we don't have the tracings.
No, but...
It's relatively stable in terms of the electrophysiology.
Okay.
That's clearly progression.
So Tony has been very helpful here. I take that. He's ruled out one diagnosis. So we have CAR. So we quite reasonably sent her to the oncology clinic. They did a ton of tests. There was a little stomach polyp, which was benign. They could find nothing. Okay. We did some more antiretinal antibodies, and she was, again, weakly positive for alpha-enolase. I'm not going to get too bogged down in... If you do antiretinal antibodies in normals, 20% carry them. There's about, well, how many antiretinal antibodies are there published now?
The problem
20?
is we only test what we test for. You react against the retina. If you damage the retina from any cause, you can often get secondary reactive antibodies, although this will be quite quick in the process. And this was tested in the UK, so Queen Square, which only tests 3 or 4 anyway.
Correct.
Yeah.
Having said that, my talk previously, we use Bayesian statistics. We've got a rapid, progressive bilateral condition. We've made attempts to rule out other diagnoses as not genetic. There's no infectious cause. She had a pretty full screen, but she has positive antibodies in this kind of picture with electrophysiological change. So it does seem to be an autoimmune retinopathy. We tried steroids, had no effect, which is interesting. And then finally, we referred her up to, sorry, I'm going the wrong way, to Bristol for some immunoglobulin therapy. You could try plasmapheresis. We have a very poor understanding of this condition, and I think there's absolutely no treatment paradigms that as far as I'm aware, that have been validated. She's steroid insensitive. Plasmapheresis could be tried. And she's currently undergoing, I think she's on her 3rd cycle of very expensive immunoglobulin therapy. My feeling is that she hasn't responded to that, to be honest. But anyway.
Yeah, I agree. These things are an absolute nightmare to treat. I've been sharing them with Gordon Plant for a number of years. We try everything. Sometimes we turn the corner with Ozurdex.
Really?
It's bizarre. We've plasmapheresed them and some of them just stabilise on Ozurdex. It's relatively benign given what you're putting her through. You've also managed to get IVIG. It was out of circulation for a bit in London.
It was a lot of paperwork, but we did it. And the other natural history is sometimes these conditions can stabilise spontaneously, or they can even, I wouldn't say regress, because you're not going to reverse some of those features. What's interesting is the OCT changes and the absence of fluorescein. Is something going on with the Muller cells? Yeah. What other conditions do that? That you have a fairly pristine macular angiogram, but you have that cystic change, sort of not quite schitic. It makes you think of genetic disorders, doesn't it? Sometimes, but there are a limited number of conditions that can do that, where the fluorescein disagrees with the OCT, and it was an interesting finding to me.
I agree. It's an interesting finding. Can I ask Adnan if you would repeat the screen for a occult malignancy?
So it's difficult. If there are no symptoms whatsoever, I tell the patient we cannot fully exclude it. And again, you're often troubled by the N of 1 case that you've been exposed to. This harrowing case of Kathy Egan's that she worked up with vitelliform-like lesions, did a full oncology systemic workup under the oncologists, treated the patient and the symptoms improved. 3 years later, had a jejunal melanoma presenting with obstruction. So I think what you tell the patient is, well, you've had your standard workup, we can't find it. However, we can't fully exclude it. And it may be your immune system has actually done its job. It's done its tumor surveillance, it's suppressed the malignancy, and therefore it's undetectable at the time, and hence you're getting the immune response. And in things like the Japanese bladder cancer literature, having anti-retinal antibodies is associated with an excellent response to treatment of your bladder cancer. So it's probably a good thing, and Mandeep, correct me if you've got any or add to that. And it may be that some of these patients, the actual aggressive immune system is a good thing, and there's always a concern if you use rituximab or something, that are you going to help the eye but worsen something else, even if you can't find anything on screening. It's a... Yep.
We're definite that he had CAR. We're sure that he had CAR. He had repeated exams for a year, every 3 months. Nothing came out on the screen. 2.5 years later, the patient had pancreatic cancer. Nobody knew, nobody could say for sure if the pancreatic cancer 2.5 years later...
So the way I would do that, we did this one with one of the early, really aggressive cone paraneoplastic syndromes where one of, not Tony, another eminent electrodiagnostician said this is definitely not paraneoplastic. We got the original bladder tumour from Bart, and we managed to persuade some of the path docs and postdocs to do immunohistochemistry. And that bladder cancer was expressing half the retina. Now, doesn't prove cause and effect, but it would be interesting if you could get the pancreatic tumour and have an academic immunohistochemistry group look at it. Just trying to get some more understanding in the area.
Anyway, we should probably move on, but okay.